Recording in progress.
Okay, so here we are at week 6. Now, before we get started, and this is for everyone, especially those watching the archive, um, I want to kind of touch on the midterm. Okay, the biggest thing to keep in mind is that these exams, both in theory and in farm, are checkpoints. They are not a verdict, and I want you guys to hear me when I say that. Okay, many of you did well. Some of you met the passing standard and others, now we have a clear path, like we have information to go on, and we can kind of know where to focus next. And I want you guys to know that is okay. We still have 6 weeks, which is plenty of time to improve with intention and consistency. Okay. Now, we're not reviewing any exam questions during tonight's live session, but keep in mind that I do have office hours um, for this class directly after at 7:15, and for 300 it's 9 a.m. on Wednesdays. Now, if those hours don't work or those times, just let me know and we can try to work something out. Okay. Now, I'm always happy to kind of work through specific topics, not necessarily go through different questions because the questions, the concepts are there, but they're asked in a lot of different ways. And I want you guys to be comfortable no matter how you see the concepts thrown at you. Okay. Now, for this evening, we are looking at diuretics, how they influence, the fluid moves through the body. We do have some poll questions, and for those of you who are watching the archive, you'll still have the same opportunity. They will be under the archive under H5P ST300 week 6 poll questions. And then, of course, for those of you that are here tonight, you can still go back and review them as well. Okay. Now, we're looking at how fluid shifts because it affects blood pressure, circulation, electrolytes, organ perfusion. Diuretics are one of the most common ways we intentionally change that balance. Okay. Now, again, you guys know that we're not administering diuretics, but we do care for patients who are going to be taking them. So that's why it's important for us to just kind of understand that the patients may be dehydrated, why blood pressure may be lower than expected, why we're constantly being, we're constantly hearing about that urine output, right? Because they are needing to void, right? So, fluid status matters a lot during surgery. Now, for our quote of the week, I think this is really big. We already know that pharmacy is complex, okay? Progress in this course comes from persistence and understanding and the why behind patient safety. Now, if it's feeling overwhelming still, that's okay, okay? I know there's a lot of different languages, new concepts, a lot of cause and effect thinking. Um, this quote just reminds us that courage is leaning and learning. It doesn't always look like confidence at first. Sometimes it looks like showing up again and trying just one more time. Now, what is expected is willingness to understand how medications affect patients, especially when those effects influence things like safety in the operating room. In real practice, no one is going to expect us to be perfect. But what matters is you guys asking those questions when, you know what, this doesn't really make sense. Or noticing when a patient's response seems different than expected, or even connecting medication effects to what you see clinically. That mindset keeps the patient safe, and it starts here. Okay. Now, I want you to think about this quietly. What parts of pharmacology feel more challenging to you right now? Now, this isn't for you guys to type. This is just for you to feel. Okay. I want you to think about, is it the terminology? Is it the mechanisms? Or is it how it all connects to the patient? Again, you don't have to answer this out loud or even type it in the chat. It's just helping you with awareness, which is actually the first step as we now start navigating towards the cumulative final exam. So, our role, awareness over administration. Okay. We play a huge role in pharmacology. Not when it comes to like giving the medications or managing the doses or anything like that, but we still have to understand how these medications affect the patients so that we can anticipate the risks and protect our sterile fields. We are the second set of eyes in the room, and that's really important. Remember, we have a lot of hats. As a CST, you're going to be present before, during, and after medications take effect on our patients. Knowing what the drug does to the body helps you to recognize when something might not be right, even if we're not the ones injecting it into our patients. So, in the perioperative setting, patients on diuretics may become more dehydrated, have lower blood pressure, require closer monitoring of urine output and any drains that may be placed. When we understand this, we can anticipate things like accurate intake and output awareness, monitoring those drainages and the urine collections. And then we're speaking up, we're communicating concerns early before they become complications. So let's walk through some responsibilities. We get into anticipation, okay? Knowing that our patient's on diuretics, that's going to help us anticipate, okay, they're definitely going to need a Foley, especially if this is a longer case, because the urine output is going to be increased. With that, we have to think about potential dehydration, so they may have to have IV fluid again during the surgical procedure. And that means somebody's got to be watching the IV and the Foley careful because we're checking inputs and outputs. We look at safety. Diuretics affect electrolyte balance and fluid volume. If those levels are off, they will delay the surgery or even cancel it. So that's why we try to understand the why behind perioperative decisions. And then again, here's that word advocacy. One of the most important roles is we're trusting, but we're verifying, right? We're checking medications on the sterile field. We're looking at labels, names, readiness. This is going to help us catch errors before they even reach our patient. So, why do surgical patients need diuretics? Well, they receive it for two reasons. You have long term management of chronic conditions, or, as you see over here, acute or short term control of fluid during acute situations. Both affect how the patient responds to surgery. Sorry, I was going way too fast. Okay. Now, I want you to notice something. Diuretics are not just like the pee pills, right? That's what we normally think. Now, they're used intentionally to manage fluid volume. Fluid volume affects how the heart, the lungs, the kidneys, even our brain functions, especially during surgery. For us as CSTs, when we're aware, it helps us to understand sometimes why anesthesia, monitoring, and we're doing maybe a different position for a case that we normally don't put the patient in really matters. And that's because it affects the blood pressure stability, tissue perfusion, kidney functions, and how well our patients are going to be able to recover after anesthesia. So now we're able to kind of anticipate how our patient's body is going to respond under the surgical stress. Now, let's start over here with the long term. Some patients take diuretics every day for chronic conditions like hypertension. Remember, that's where we're trying to lower the blood volume to reduce pressure, or CHF, which is congestive heart, yes, the blood pressure, congestive heart failure, where we're trying to reduce fluid strain that is on the heart. These patients often arrive with, they already have their established routine of fluids and electrolyte baselines that are already going to be different from our typical patient that's not on this. Right. A lot of times, it's a lot of our cardiac patients, most definitely, especially if you're leaning towards cardiothoracic surgery. Just know many of your patients may already be on, or vascular cases too, may already be on some type of um, diuretic. Okay. So we think about what might that mean for blood pressure or hydration during surgery. Okay, so you kind of think about that. Things that we're already going to be looking at because their baselines are already going to be different from our patient that is not normally on a diuretic. But then we move over here to the short term. Other patients, they receive diuretics just temporary because we're trying to manage a specific risk. The goal here is rapid fluid reduction, not long-term treatment. So some examples would be, we go back to intraocular pressure. We're trying to lower that, right? For eye surgery. Um, we want to bring a patient in because they have increased intracranial pressure. So there's a neurological risk, right? Um, and sometimes we just need to support or protect the kidney function, especially with a patient with edema. But we have to be careful with edema, and I'm glad you brought that up because that could be chronic or acute. So either way, right? We still want to make sure that we get that fluid down. And I love that you brought that point up. Now, if a patient has been given diuretics shortly before surgery, what changes might you expect in fluid status? Like, what is one thing you're going to automatically be thinking? We just gave them a diuretic, and I would use one of the words someone's, yes, more fluid output. Most definitely. And you can type in yes or no. Could this influence anesthesia? Like how they would do things? Yes, most definitely. And it's also going to be something that we're going to be looking at for intraoperative monitoring as well. You guys are right on path. Now, when we start to understand why diuretics are used, we stop seeing the medication as kind of like a background noise and we start seeing them as, okay, this is really about our patient's story. Now, the slide that I was trying to get to, we get to the mechanism where salt goes, water follows. The big thing about electrolytes, okay, you guys, they work by controlling, or diuretics work by controlling electrolytes, especially sodium. When sodium stays in the tubule, water stays with it and leaves the body as urine. Isn't the so is the diuretic placed on hold? I think that's what you're saying, right? It depends before surgery. Okay, so it depends on the patient's condition, depends on what the patient's in there for, because a lot of times they may need to have that surgery to make sure that they're balanced before they can go in. And um, it depends on why they're there in the first place. So there's a lot of different factors. So I can't say automatically yes. In a lot of cases, we will put it on hold, but it's going to depend on, A plus B plus C with the patient. Okay, great question. Does everyone understand why? Okay. Now, but here's the golden rule that I want you guys to hold on. Again, kind of like in this sentence right here, where salt goes, water follows. Your kidneys do not move water directly, they move electrolytes. Water follows along naturally. So that's kind of really the misconception. Okay. Normally, what happens is your kidneys themselves reabsorb sodium back into the bloodstream. When sodium is reabsorbed, water follows it. So fluid kind of stays in the body. Diuretics change the pattern. Diuretics block the sodium reabsorption. Sodium stays inside the tubule, water stays with the sodium. Both leave the body as urine. That's called diuresis, increased urine output. Okay. Now, for us, we just got to know more sodium equals more water out. More water out. Now we're talking about lowering the blood volume. And lower blood volume affects blood pressure, it affects circulation and tissue perfusion during surgery. That's really big. Okay, you guys? Again, more sodium out, more water out. More water out, lower blood volume. Lower blood volume affects blood pressure, circulation, and tissue perfusion. Okay, that's when you put on a potassium if you're on a diuretic. Yes, that's commonly when a potassium is kind of discussed with the patient. So yes, 100% you are thinking right on point. Yes, yes, yes. Now, there is a hidden risk though. Hypokalemia, low potassium. It's so funny you said that. And this is why. This is why you're put on it. It's like you were reading my mind. Now, because diuretics don't just remove the water, they remove electrolyte, especially potassium. Low potassium increases cardiac and anesthesia related risks during surgery. So we call that hidden risk because you can you can't see it just by looking at the patient. When diuretics increase urine output, electrolytes, they're going to leave the body along with the water. Potassium is, and hear me when I say this, potassium is the most critical one that we pay attention to because it plays a major role in how the heart and muscle function. So, yes, it is huge in cardiology procedures. Okay. But with the heart, period. Why? Low potassium affects heart rhythm, how our patients respond to anesthesia, um, how there's a response to different muscle relaxants. That's why potassium levels matter before the incision ever happens. So let's bring it to the real OR. Okay. We're in the operating room, we're getting things set up. Low potassium increases the risk of cardiac arrhythmias. Now we're thinking about, are we able to put this patient under anesthesia because that can even increase the risk that much more. Muscle relaxants may have a stronger or prolonged effect. This is why, in some surgeries, they are delayed or paused, not because of the procedure itself, but because of the patient's safety first. Okay, you're going to often hear a normal potassium range mentioned. What you're really looking for is recognizing when the potassium described as low, that is a safety concern. Why? When potassium is low, the heart becomes irritable. Now you're starting to see irregular heartbeats occur. The patient becomes more sensitive to anesthesia and muscle relaxants. That combination by itself raises risk during surgery. So we look at this tip right here, okay? If there is any question about the potassium level for our patient, we are not opening that sterile field. We're going to usually just be on standby, okay? The anesthesia provider has to go and determine if it is safe to even proceed. The decision to protect the patient, and that also protects the surgical team. Yeah, they're checking the blood work. Yes, most definitely. They're checking to see. Now, if a patient has been on diuretics and their potassium is low, why would anesthesia be especially cautious? Just on what we just talked about. Why are they worried? They're on diuretics. Yes. Cardiac risk. They're looking at the kidneys. Yes. Now, let's throw another question on this. How does delaying a case actually prevent harm rather than causing it? I think, yeah, the body can shut down for safety. Yes, exactly. We're not going to bring a patient back to the operating room and potentially lose them knowing that it's safer, right? To save their life to, you know what? Let's get their levels up before we even bring them back because we know what anesthesia does to it, because we already know what muscle relaxants do to it, and we already are worried about any type of heart arrhythmias with them being on a diuretic and already having low potassium levels. Yes. Now there's a couple agents that you're going to see that you may even have on your back table or even in the room in the operating room. Okay? So you see two types on the slide. As an ST, when you see certain medications on your field, you should automatically think, what is the goal of this particular drug? What changes may happen quickly? And that's important because in the back of your mind, you're like, okay, if this drug, sometimes this could happen, what do we need to have ready? And what should I be ready for next? Now, that awareness by itself supports patient safety and team efficiency. So we look on the left, okay? We have mannitol. This is an osmotic diuretic. But here's the big picture. Mannitol, especially for those of you that are planning on going into neuro or eyes, mannitol is often used in neurosurgery and ophthalmic procedures. Its purpose is to reduce pressure, not to treat routine fluid overload. But what do I mean by pressure? Well, we're looking at ICP, intracranial pressure, or eye pressure. What it does is it pulls fluids from tissues into the bloodstream first. This means fluid shifts happening before urine output increases. So it takes the fluid where it shouldn't be and put it in places that it can be useful. But here's one thing to keep in mind. Mannitol can crystallize, especially if it's cold. This is why it is going to be warmed and fully dissolved before it's used. Okay. A lot of times you may see, this is something that you actually may see anesthesia or nursing just addressing, like you'll see them kind of warming it up before it's been administered to the patient. So for us, if mannitol is being used, we're already going to be expecting changes in fluid balance. We're going to be prepared for increased urine output later. So the Foley, they're going to really be checking the Foley to make sure that, how much is output. And then for us, we're just understanding that, you know what, mannitol's been given. We're thinking ICP or some type of IOP, intraocular or intracranial pressure. Okay. Now we come over here to Lasix. You see, this is called a loop diuretic. Lasix is commonly used for fluid overload, again, during sometimes intracranial procedures as well. Now, with furosemide or Lasix, it has a rapid onset, often within 5 to 15 minutes, causes quick urine output. From here, we're going to expect the bladder to fill rapidly. That means that Foley, suction container, or even drainage, they're going to be looking at it big time. Okay. We're anticipating hearing a lot about fluid. Let's say you're doing a urology case and this is on board. Maybe we were doing even a kidney transplant. Okay. You're going to be thinking, you're going to be hearing, they're waiting for that urine output. They want to make sure that everything is working correctly. So, what about furosemide? Now, this is also a loop diuretic, and it can also lower potassium. So, that is another one that you will hear. You may, depending on the surgeon, if they've used it in the past, but a lot of times, the one that you'll see a lot is furosemide, but it's still one of the samides. Okay, it's still one of the loop diuretics. Now, for furosemide, um, when there's more sodium and water that's excreted, potassium, we already know, is going to often be lost as well. So, with any of these drugs in the operating room, they're monitoring the potassium levels with labs. So that's why they check them before they come to us. And again, if the levels still don't rise after they've checked them, after they've given them treatment, then again, the cases will be paused. Depending on how it, like, if it's a, it depends, like, if it's one of those where the element is worse than them not getting it, they may still have to, if it's like a true life or death situation. But if it's one where they can get that level up first to save the patient's life, that's what they'll do. Okay, so it all comes down to what is the path of least resistance to make sure that we are protecting our patients and also addressing while they're here in the first place. If that kind of makes sense. So let's think of this together, okay? Mannitol given during a brain case or Lasix given during surgery. We think about what changes in the room or the patient care and think about what you might have to anticipate next. Okay? I want you to be thinking of urine output, thinking about what are we monitoring and what are you going to be ready for depending on which medication the patient has been given and the surgical procedure. Because a lot of times in cranies, you got to think about the patient's positioning. Okay. We have patients that are awake during cranies. We have patients that are connected to the Mayfield, where we kind of drill into the head, and that Mayfield is what's holding the patient's head. Sometimes they're prone, sometimes they're supine. It just depends on, why the patient's here. Mannitol pressure. Explain a little bit more what you mean before I try to guess.
Sorry, because I just know in the beginning you said something about mannitol was like for pressure, and then I
Ah,
can't
okay.
say it.
I see
The
what you're
loop
saying. Okay.
diuretic was for
Output.
just for like
Yes.
urine output and stuff.
Yes. I just want to make sure I got it before I said it.
Okay, no
Yes.
problem. I just wanted to make sure also. Thank you.
You're good. Mannitol. And these are excellent questions. You guys keep them coming. Mannitol. I want you to think of, again, pressure, right? So ICP, intracranial pressure, because you may see it either way, or IOP, interocular pressure. Okay. Pulling the fluid from the tissue into the bloodstream. Okay. Mannitol is used for pressure management. Full stop. Furosemide, I always say it wrong, is going to increase urine output. It's going to treat fluid overload, and it's used in heart failure or pulmonary edema, and sometimes some kidney cases, so sometimes renal issues. Okay. So that's really the difference between an osmotic diuretic and a loop diuretic. One's for pressure, one's for urine output. Okay. All right. You're welcome. So now we're talking about the back table. Not our Mayo stand, but our back table. Okay. The one thing about diuretics is they still influence our setup, our monitoring. And we also have to understand how they're administered. Um, the thing is, a lot of medications you guys are seeing, they do not exist in isolation. They change what equipment is needed, how the room is set up, what the team watches closely for during certain procedures. Most diuretics are given by IV by anesthesia. One important exception is mannitol, which may actually appear on or near your back table. And that's really going to depend on your procedure and the protocols of that particular facility. So again, we go back to trusting but verifying, verifying label, checking concentration or percentage, right? And then confirming expiration date, right? Trust but verify. For the fuel gauge, we come over here. Because diuretics cause rapid bladder filling, urine output becomes one of the clearest indications of how the patient is responding. Okay. That's why we have the Foley that's often required when we're using some type of diuretic. Um, so, in real cases, diuretics can quickly increase the urine output. Okay, we look at measuring, that's going to be one of our important indicators. And then delays in catheter placement can actually interrupt the workflow. So that's going to be one of the first things that we do. We get that fully in and you're breathing. And I say we, but our circulator. Okay. Now let's get some clinical reasoning. Let's connect some of these dots. So we look at the two images, and instead of seeing these as separate facts, I want you to see them as connected ideas. Okay? Each box answers the same question in a different way. What is the safest way to move fluid for this particular patient? So we have to understand the reasoning, okay? Trying to follow the clinical logic. We're looking at anticipating the risk. We're trying to recognize when patient safety is driving a particular decision. So we get the sodium blockade. We get to the core idea. Diuretics work by blocking sodium reabsorption. If sodium stays in the tubule, water stays with it, and remember, it leaves the body. That is really the foundation for treating fluid overload. So if a drug blocks sodium, what happens to water? Because remember, the water is going to follow the sodium. If the sodium is blocked, is it feasible to think that the water could be blocked as well? Just a think, just a think, just just a thought. Okay. Now, there's an osmotic contraindication though. Mannitol pulls from tissue into the bloodstream first. That temporary increase in blood volume can raise blood pressure. And then we have to think, why does this even matter? For patients with hypertension or heart failure, that temporary volume increase can be really dangerous. So mannitol may be avoided. And it's not that mannitol is bad. It's that the mechanism doesn't match for every patient. Again, it's not a one size fits all. Now, potassium sparing diuretics down here, I want you to think about some patients that just cannot afford to lose more potassium, but still need mild fluid reduction. That's where potassium sparing diuretics come in because they kind of reduce the fluid gently, reserve the potassium, and are lower potency just by design. So, again, the choice is based on what the patient can safely tolerate. You may hear we're avoiding this because of potassium. The patient can't handle a volume shift. We need something gentler. Okay? They're telling the surgeon. We're doing our thing, but they're telling the surgeon. So you're hearing these things. The decisions aren't going to be random, they're based on mechanism and what's going on with our patient at that time. So here's a question for you. You have two patients, they have excess fluid, but one has heart failure and one has low potassium. Would the same diuretic make sense for both of them? Right, it wouldn't, right? So as you can see, this already helps us to kind of understand the why um, certain medications are used for certain patients. Now, I want you to think of this slide as a snapshot, okay? Something that could really happen, okay? Nothing dramatic has happened yet. No alarms are going off, but there are clues already there. And this is where our kind of spidey senses as CSTs really matter the most. Okay, so I want you to look at what we know. Our patient is Miss Hernandez, who is 85 years old. She's coming in for a hip prosthesis. So, hip arthroplasty, pretty much. But she does have a history of chronic hypertension and long term diuretic use. Individually, none of these are alarming, but together, they start to tell us a story. Okay? We're often the first people to kind of see the chart. Sometimes we're the first, the surgeon comes in and tells us what's going on with the patient because we're in there, we're getting the room ready. We'll hear the report and then we start the setup. That puts us in a unique position because we're able to connect dots before sterile supplies are open and anesthesia even is begun with our patients. So let's put this together, okay? Long-term diuretic use, which lets us know that there's an increased risk of electrolyte loss. Patients at an advanced age, which means there could be decreased psychological reserve. And we have to think about the anesthesia part, increased cardiac sensitivity. You put all this together, now we know that this particular patient has a higher risk of hypokalemia, which we also know can lead to cardiac arrhythmias when the patient is under anesthesia. Now, this is where our role becomes real. Before opening even your sterile gown and gloves, we pause, we verify. Has the patient's potassium levels been checked? Because that's going to be big. This isn't questioning anyone's competence. Like, we're not saying, hey, doc, did you go ahead and check that? We're not doing that. We're just trying to make sure if this is one of those green light to open or yellow for pause. Okay? If this case is canceled after sterile supplies are opened, hundreds of dollars in supplies are wasted. Now we have to delay turnover. And then, of course, there's going to be stress with the entire team. So, just by asking that one little question, we are really speaking up. We're protecting the patient, we're protecting the team, we're saving the facility resources and money. Okay? They can't get mad about that. All right. Now, you're going to be asked to think like a CST. Okay? Consider timing, observation, and interaction between medications and patient responses. In the operating room, Patient safety really depends on when something happens, what changes that we notice as CSTs, and how different factors did interact. When you respond to different questions, I want you to think about the sequence, okay? If a diuretic is given shortly before surgery, how might fluid loss affect blood pressure? How could that influence anesthesia stability or even recovery? When you're approaching the second question, this question is about awareness, not diagnosis. Okay? I want you to think about changes in urine output, blood pressure trends, signs that something just feels off. You're practicing noticing these different patterns that might suggest, wait a minute, that looks like it could be an electrolyte imbalance. For the last question, granted, you're not answering these, I'm just trying to show you how to think through them. We look at medication combinations. The question invites big picture thinking. Diuretics do not act alone. All right. So you consider anesthesia, muscle relaxants, cardiac medications. I want you to be thinking about, wait a minute, how might these combinations increase risk or require close monitoring? You focus on interaction, not um, recall so much. Recall, you need to know, but kind of put it all together. Okay. Now, if you're standing in the operating room, I want you to think, how would this information help me protect the patient? And yes, I know we're at module 3, but you'll be at module 4, module 5 before you know it. We're already at week 6. Okay. So keep that in mind. The last thing we talk about before I present to you guys the poll questions, um, we look at our clinical judgment. It really does improve when we pause to kind of think through timing, signs, interactions. Okay, this helps us to kind of organize our thinking before applying in discussion or even in practice. So here's a question: if a diuretic like Lasix works in 5 to 15 minutes, hint hint, when would you expect urine output to increase? When might blood pressure begin to drop? So we know that it starts working in 5 to 15. It's reasonable to think between 5:15, right? Reasonably, okay? It's not about exact minutes, it's just anticipating sequence. The patient was given 5 to 10 minutes. About 15 minutes, our nurses are going to be starting looking at that Foley, or our circulators are going to start be looking at that Foley. We start thinking, what happens first? What happens next? Urine starts to increase. So now we're looking at different things with blood pressure and different other things that could potentially happen. Low potassium affects the heart. Remember, changes rhythm, muscles, weakens, or even altered muscle responses. What would make us pause and pay closer attention? Okay, you're going to be noticing things from anesthesia. You're going to be hearing. You're going to be when I say you're going to be so hyper vigilant about your rooms, I promise you you will. Okay? Yes, it does. Peeing does, or voiding does make a difference in blood pressure. Yes. Yes, yes. And so I'm using voiding, but it's peeing. Um, but yes. Now keep in mind that diuretics do not act alone. When we add our anesthesia, when we add those muscle relaxants, and we add the body's response, that can definitely change, especially on our elderly patients. Thank you. Remember, our patient that we just talked about is 85 years old. Also consider, if electrolytes are low, how might cardiac muscle respond? How might skeletal muscle respond based on what we already know? Why might anesthesia providers stop, pause, and be a little bit more cautious? Think interaction, not isolation. Definitely, definitely, you could look at muscle spasming. You are thinking right on the right track. And I love that. Yes. Okay. So as we get closer to cumulative exam, I wanted to make sure that you guys were seeing every potential um, concept brought to you in every potential way. So for those of you that are here, you will have, let me get the timer working. 5 minutes. There's 10 questions. For those of you that are watching the archive, there is going to be a section underneath the archive once this goes up, and you'll see HP5 ST 310 week 6 poll questions. They'll be the same questions that they have here this evening. For those of you here that are here, you can go back to that as many times as you guys want and just kind of build up that confidence as we get closer and closer to the cumulative. I can't promise I'll be able to do this every week, but I am going to do my best to kind of go through, get different concepts from the current week. And I will do my best so that you guys can kind of have an additional resource as we gear up. Okay. But it is up. Once the timer is done, I will come back. All right. Stop. Okay. So let me end and share. Okay. So again, like I mentioned, for those of you that are watching, you will have the same opportunity to answer these questions if you choose, no pressure. And then for those of you who are here, um, underneath the archive, you'll see HP5 and you can kind of go through again. Okay. Now, keep in mind, pharmacology is not limited to medication administration. We cater this for us in the operating room. Okay. Now, what I want you guys to take from this class: bladder distension. We're anticipating catheter placement, okay, because we put a lot of Foleys in our procedures. Medication errors. We're always trusting, we're verifying. We're verifying labels, preparation, especially with agents like mannitol. And then we look at cardiac events. Um, we respect potassium levels. We respect potassium levels and the timing. These are just small little contributions, but they're really important when it comes to patient care. For those of you that are watching the playback, how might the timing of diuretic administration before surgery influence a patient's intraoperative stability and postoperative recovery? What signs should we as CSTs watch for in the operating room that could actually indicate a patient is experiencing electrolyte imbalances due to diuretic use? And how could the combination of diuretics with other common surgical medications create potential risk or require extra monitoring? Let's talk about it in the discussion forum. Before we get out of here, what questions do you have for me? Okay, so I do want to leave you guys with the quote of the week. Sometimes courage is that quiet voice at the end of the day saying, I will try again tomorrow, which is really fitting. Okay, now with that, um, I will be in office hours at 7:15. There is no pressure. If you would like to come for pharmacology, I am there. Um, I want you guys to have a good rest of your evening, and I do look forward to everyone who can attend tomorrow's live session. Good night, everybody.